and welcome back to another insightful episode of MedSynapse podcast series where medical minds meets innovation. And today we are diving into total knee arthroplasty, a procedure that is seeing rapid evolution in patients' profile, technologies, and outcomes. And joining us is Dr. Abhishek Mehta, an experienced orthopedic surgeon from Ahmedabad with over 10 years of experience in the field. He has studied extensively in hip and knee arthroplasty, including robotic procedures, and has been part of over 300 joint surgeries. So let's get into what's new, what works, and what every clinician should know. So welcome to the show, doctor, and it is such a pleasure to have you with me.
Thank you so much for having me.
So doctor, could you walk us through the indications of TKA that have evolved in recent years?
The thing about TK is that it has evolved recently so much in a younger age population. Maybe 10 years ago, it was mostly done in a population younger than 60, around 60, not younger than 60, but somewhere around 55 to 70 was the age, the trending age when knee replacement was done. But at present, owing to our lifestyle, our diet, it has shifted a little bit earlier. At present, I have operated patients somewhere around the age of 45 also. After the age of 40, many of the patients are now getting arthritis. The symptoms of arthritis starts at somewhere around 40. And by 50, many of the patients are now requiring surgery. This current trend is mostly due to our diet changes. And another important factor, the lifelong weight that we had. Mostly obese patients with a BMI somewhere around more than 25 are more prone to get arthritis at an early age compared to the thin and lean patients. So that's one of the things that has been recently changed. Another thing is increasing life expectancy. We are now operating patients of even more than age of more than 80 years. If the patient is fit, he has no cardiorespiratory illness and has a good fitness overall. Knee replacement can also be now done in patients with the age of more than 80 years. So that has now also increased knee replacement at a later age. So these two age, which were usually not, where knee replacement was not usually performed, it has now been started before the age of 50 and after the age of 80. These are the two extremes where usually in the past nobody used to prefer knee replacements, but due to the conditions of knee and all, they have started doing knee replacements.
Yeah. So, doctor, just a quick one follow-up question: that are younger patients undergoing surgery more often now than before?
Yeah, definitely. It was, maybe a patient in 1,000 before in the past that under the age of 50 that will get a knee replacement. But now, almost every fourth or fifth patient between the age of 40-50 has developed arthritis. And even 1-2 patients of every 100 patients have significant arthritis that required some sort of surgical intervention. Maybe not a total knee replacement, maybe a half knee or a unicondylar replacement, or maybe a HTO, that is a joint preservation surgery. So yeah, under the age of 50, many young population has now started developing arthritis, which requires some sort of surgical intervention.
Yeah, so it seems that we're not just seeing more knees replaced, but also active lives being impacted as well.
Yeah, definitely. Active life, the age that we carry throughout our life, that is one of the most significant factor that I even emphasize in my routine OPDs. If you are obese throughout your life, there are very good chances that you develop arthritis before 50. So that is something that we should be controlling from an early age. Never neglecting your knee injuries. Many of the people now neglect their knee injuries, their knee pain. They are like, it's fine. But that's not fine. If there is a knee pain at an earlier age, get it diagnosed, get it treated. So maybe arthritis can be prevented at a later stage. Maybe delayed. It cannot be prevented, but maybe delayed at a later.
Yes, correct. That's, I think, rightly mentioned by you. So, doctor, now, speaking of evolution, what are your thoughts on robotic-assisted TKA versus conventional methods? And do you believe that clinical outcomes justify the hype and cost as well?
Yeah, definitely. Robotic knee replacement is something that has emerged over the last 5-8 years. It has been almost after 2015 that robotic knee replacements have been on a rise. The major advantage robotic knee replacements offer over the conventional one is that the small margin of error that a human may face, a robot that eliminates that error. So you can get a near accurate knee joint. with the robotic knee replacement. And certain principles of knee arthroplasty are much more precise. It can be done on a robot only. That certainly helps in your knee. Definitely the recovery time theoretically it does improves after robotic knee replacement. Costing wise, yeah, it is a little bit expensive, but if everything else is fine, definitely robotic surgery can be undertaken. It's a very efficient procedure, and the main thing is it minimizes that margin of error. That margin of error that a human can have, that is human is expected to have, that does not happen with a robot. So definitely robotic does have certain advantages over conventional. But yeah, conventional is also fine. People have been doing conventional knee replacement since like 25 30 years. uh, there are patients whose knees are working for the last 20 to 25 years, not giving them any problem. So definitely total knee conventional way done by a nice surgeon at a nice center definitely works also fine. But yeah, if access to robot is there, definitely one should prefer for a robotic surgery rather than a conventional one.
Yes, I think it's great to hear that, technology isn't just flashy and it's just refining precision and confidence
Yeah,
in
yeah,
surgery.
definitely. It's refining precision to a very good extent.
Correct.
The time definitely for the surgery increases, but we can get the precision we want.
Yeah.
Maybe with the instruments that we use with the human touch, it is not possible to that extent. But with a robot, definitely you can get it to a pinpoint accuracy to not to a level. The margin of error is less than 1 mm with a robot, so
Yeah.
definitely that helps a surgery.
Correct. So now, doctor, let's talk about complexity also. So how do you handle patients with significant deformity or comorbidities like uncontrolled diabetes, rheumatoid arthritis, or obesity during TKA planning?
See, obesity is one of the common big reason that PK fails, primary replacements fail, that patient requires resurgery of the knee. So definitely, weight loss prior to a surgery is a very much emphasis upon. If a patient gets his weight down prior to surgery, it helps him before the surgery, during, and also after the surgery. The time required for rehabilitation is less. The time required to return to a daily function is less. So definitely, obesity does play an important role. About the other thing that you said, diabetes. This is a planned surgery, so we always get time. That it is not like that you have to get it operated in a week only. You can definitely plan it out. If there is uncontrolled diabetes, we can get it under control. We have a number of anti-diabetic drugs and even insulin to control that. Once we get that under control, we usually operate after that, because uncontrolled diabetes will definitely increase the risk of infection. We target an HbA1c of around 8.5. If it's below that, we can operate, but if it's above that, we need to optimize the blood sugar control after that. And with obesity, the cost of implant also increases. We need to put a special rod inside your knee, inside your bone, that will help to prevent that early failure of a knee because of weight. So the cost of your surgery increases, the time taken for surgery increases. So definitely weight loss helps. But if there are significant deformities, the current implants and instruments that are available, it can very well be done. There's not an issue. There are different types of special products available for complex deformities. Definitely, they are a challenging surgeries, but they can be done, and patient can get a normal knee, even if there are complex deformities. And complex deformities are mostly due to patient waiting out. They do not want to get operated. They are like, we won't get operated. And when at the last stage, when they are not able to walk, they are coming to us to get operated. And at that stage, the deformities are to an extent that a simple basic knee won't work. So my recommendation, what I suggest is that if you're having significant pain, you are going to need a tablet daily, a painkiller daily, or need to take a painkiller daily to work, better to go for a surgery, better to get your knee replaced, so you can live a pain-free longer life.
Yeah, I think that actually that approach really highlights the surgical foresight that is actually required also sometimes.
Yeah,
So,
definitely.
doctor, pain management often becomes a bottleneck for early rehab. So, what multimodal strategies do you use that you have found particularly effective?
Yeah, something that I have find effective. are regional blocks. The anesthetists give injections in your nerves. That definitely helps for the initial pain. The initial 24 to 48 hours after the surgery are much painful, and many a times the patient are apprehensive of that pain. For that, to avoid that pain, they are not willing for the surgery. Definitely femoral blocks, the femoral nerve blocks or the adductor canal blocks, they definitely help with the pain. They will cause, they will decrease your pain by 70 to 80% in the first 24 to 48 hours. Then there is a technique called perioperative injections that we give around your knee. After, during the surgery, we give it around the knee. That reduces the inflammation, that reduces the pain, that reduces the swelling. The current techniques, we have that minimally invasive knee replacement where we do not cut the muscle. Not cutting the muscle again helps with pain and swelling. Minimal exposure, minimal time of the surgery. All these factors also help in the pain management. And post-operatively, we have a strict, definitive, guidelines how we proceed. We have certain medications that we can give. We make sure that our patient does not have more than mild pain. I'm not telling that the post-operative period will be painless. Definitely some pain would be there, but we are having a system of medications that have been arranged in such a way that it is never more than mild pain. Maybe on a VAS score, it will be somewhere around 2 to 3. There will be some discomfort, but definitely not more than that. Pain after surgery definitely impedes our rehab also. The physio is delayed because of these patients. Walking is delayed because of pain. So yeah, managing pain during and after surgery does help with that better rehabilitation. The current trend that we follow is that we do not push for aggressive physiotherapy post surgery. As long as the patient is comfortable with the current trends, with the current implants, it is very easy to obtain the range of motion even after a few days. But the thing of prime importance is patient comfort. As much he is comfortable, he can exercise, he can walk. There is no need for the aggressive exercise that used to be done in the past to get the range of motion. So definitely that is a no-no. We have started that deep vein thrombus profile exercise also started on the second day. We make sure that the cross doesn't develop in the leg bones. We encourage the patient to walk. All these measures, help to relieve the pain to a much extent. Yeah, early physio also helps with relieving the pain. The fluid around the knee joint, it moves around, the pain decreases. So all these factors definitely helps in pain improvement. And currently where I practice, I make sure that my patient does not have more than mild pain during his entire hospital stay.
Yeah, I think those are crucial outcomes also, doctor. And
yeah, definitely.
These outcomes sometimes even and it should go beyond the OR as well. So it's really important to see the post-op also. So, doctor, stepping beyond the OR only, so what do you wish non-orthopedic physicians knew about TKA, especially around referral timings, red flags, or managing patient expectations also? Sometimes that is also where something wrong can happen.
Yeah, regarding referral patients, if somebody, the classical signs of knee arthritis without getting an X-ray done, there are definite few things that we can see and get an idea whether this patient has arthritis or not. His walk, if he's swaying on both the sides while walking, that is one of the signs. Many patients don't have any pain, but while they're walking, they will sway to a degree of 30-40 degrees on either side. So that swaying is a sign that they are not putting weight on their knees. The brain is tricking them not to put weight on your knees because it will hurt if you put weight. So one thing is that. Another is a sound coming from knee. Crepitus is that what we call it. A sound coming from knee is another sign of arthritis. If a patient is having any of those signs, they are not able to walk comfortably, or if they are swaying on either sides, or if there is crepitus in the knee, and there is a classical deformity of knee. The legs are inverted V or C. Both the ankles are together and the knees are getting away. So that is a classical deformity that we see in majority of patients. If any of those signs are there, they can definitely refer a patient to an orthopedic surgeon, or they can get an X-ray done. X-ray, I recommend always get standing X-rays when the patient is bearing weight on the knee. That will provide an exact idea of the joint space. If there is significant narrowing, if both the bones are touching each other, that is definitely indication for surgery. Regarding the red flags, if patient has diabetes, hypertension, or any other cardiac or pulmonary illness, or any systematic illness, it is better to optimize that. This is a planned surgery. This is never an emergency. This is an elective surgery. There is never an emergency. It is important that the patient is functionally stable and fit for the surgery, because if the rest of the body is fit, he can definitely survive a knee replacement implants. So that is one thing. Yeah, and regarding the post-op protocols, patients usually stay for 2 to 3 days post-surgery. During that period, also optimal control of his bodily systematic functions, the kidneys, the heart, the liver, the lungs should be working absolutely fine. The referral doctor should make sure that after the patient is discharged, that they are in optimal conditions. The knee are working fine, but the generalized condition of patient should be fine.
I think those are some practical insights, Doctor, that you've shared with us today. So before we close today's episode, Doctor, one growing debate in orthopedic circles is UKA is changing current trends in TKA. So total or half, what should be done, and how do you approach this decision?
See, there are certain criteria for half knee replacement. They have been extended to a lot. So almost 50 to 60% of patients getting the total knee done can get a half knee done. The advantages of half knee is half the incision, half the pain, half the swelling, half the recovery time. Everything is half. I've seen patients of international doctors doing skiing after getting a half knees done. So it feels much more natural. Your ligaments, all 4 of your knee ligaments are preserved in a half knee replacement. Usually there are 2 spectrum of ages for half knee. One is less than 50, below 50, where a total knee would be too early. Less than 50, if the age is less than 50, there is if the patient is falling under certain criteria, a total knee would be too much early. So half knee can be done there. And there is another age group that is above 70. It is said that if your knee is working fine for more than up to 70 years, after 70 we can definitely get a half knee done, because usually they don't have that much significant arthritis. And preserving a age also puts much less stress on their body, and that also helps with a better post-op recovery. So UKR definitely can be done in much amount of patients. It's not that much prevalent yet, but if the X-rays are matching certain criteria, and if the patient is having pain in similar areas, definitely UKR is much more better in terms of recovery, pain, swelling, and return back to daily life. It works fine for 15 to 20 years. Usually there are no issues with the current implant designs. So if possible, UKR can definitely be done over TKA in any patient.
Yeah, I think that clarity really helps, Doctor, and thank you so much for decoding not just the surgical side of knee arthroplasty, but the broader clinical thinking that drives it. So thank you so much for sharing that today with
Sure,
us.
definitely. Thank you very much.
For all our listeners, whether you're referring, operating, or rehabbing, today's insights bring us one step closer to better outcomes and more empowered care. And remember, if you're a healthcare professional who's eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, stay aware and take care of your health.